This is Dr. Mohammad Helmy. I'm the head of department and the lead mentor of MRCOG Part 1 courses at Mid-Exam Expert. And I'm so glad to have you with me in this webinar. Today, we are discussing a quick introduction for anatomy. I will talk quickly about the pelvic bones and pelvic diameters. This is just a warm-up introduction for anatomy, and after that I'm going to discuss a quick orientation about our regular course and what is our plan during the course. So this is for our dear colleagues who already joined the course, and also for other colleagues who want to know more about the mid-exam regular course and what is the exact and entire plan for preparation to the June exam, inshallah. So, of course, we know that anatomy is one of the very important subjects, and actually, anatomy questions is like 25% of the paper one questions. Okay, so focusing on the anatomy of the pelvis and the pelvic organs, especially, of course, the female genital system, is the cornerstone of studying anatomy for MRCG Part 1, besides some other topics that is covered during the course, inshallah. So before going through the orientation about the course and everything, I will start talking about the anatomy part and discuss with you the pelvic bones and the pelvic diameters. And for our dear colleagues who already joined the course, of course, this is a very important part, and it's a part that you have to study and cover before going through the main live session for anatomy. So when we start our main sessions or the live session phase, you have to cover this webinar and study it before going through the main live sessions. So the bone of the pelvis is like a skeletal ring. It's like a skeletal ring between the head of the femur. Of course, the head of the femur is articulating here at the acetabulum. Okay, this is the head of the femur, and the fifth lumbar vertebrae, which should be here. Okay, above the sacrum. So if we imagine that we have a ring joining the two femurs, okay, and the fifth lumbar vertebrae, this skeletal ring is made of the pelvic bones, which are the hip bones in the red color, okay, the sacrum in the yellow color, and the coccyx, which is in the blue color. Of course, we have the hip bones can also be called the innominate bones. The innominate bones, or the right and the left hip bones. So each hip bone is formed by the fusion of three bones. These bones are the ilium, the ischium, and the pubis. The ilium in the red color, the ischium in the green color, and the pubis, which is in the yellow color. These three bones, the ilium, ischium, and pubis, are joining together at the acetabulum here. The acetabulum is the bony cavity where the femur head articulates. So this is the place where the three bones join together. And if we look at this picture here, as you can see, that's the acetabulum, and this is the articulation of the three bones. Before puberty, there is a cartilage joining the three bones together. We call it triradiate cartilage because it's containing of three lines like that, similar to the Mercedes, symbol. So this is called the triradiate cartilage, and separate these parts. And the fusion of this cartilage begins at the age of 15 to 17. So if we go back at this picture again, there is a place where the ilium or the iliac bone, which is in the red color here, and the pubic bone, which is in the yellow color, articulates also or join together. This part is called the iliopubic eminence. There is an elevation here at the site where the two bones join together. We call it the iliopubic eminence. The iliopubic eminence. Of course, knowing these landmarks is very important, because when we talk later on in other sessions of anatomy, like when you talk about the pelvic ligaments or muscles or whatever, and say that the origin of the muscle or the ligament or insertion of the muscle or the ligament at this part, we should of course understand what we are talking about. Okay, like exactly what is the insertion or the origin of this muscle, what are the articulation sites or attachment sites of a certain ligament. So knowing these bony landmarks are extremely important. Beside, of course, it helps us in applied anatomy, like I'm going to mention in a while. So these are some important landmarks we have to consider. Okay, so this is the bones, or these are the bones of the pelvic girdle, and we have some, you know, uh, uh, landmarks also to consider. We have what we call the iliac crest. This is called the iliac crest, what I'm marking now with the red color. This is the superior border of the ilium. And consider the soprolateral margin of the greater pelvis. Okay, so this is called the iliac crest. We have also the greater sciatic notch. This is called the greater sciatic notch. And this is one is called the lesser sciatic notch. They are separated by what we call the ischial spine. This pony projection here at both sides here, it's called the ischial spine. So this is the greater sciatic notch, and this is the lesser sciatic notch. And of course, from the applied anatomy parts that we are going to mention in other lectures, the structures passing through the greater and lesser sciatic notch. And this is a very important exam question. Like, they can give you a single best answer asking you all the following structures are passing through the greater sciatic notch except, or which of the following structure is passing through the lesser sciatic foramen. And these are kind of anatomy, very famous anatomy exam questions. Okay. Also, we have what we call the arcuate line. The arcuate line. The arcuate line is a smooth, rounded border on the internal surface of the ilium. Actually, this one. This one is called the arcuate line. It extends here from the sacroiliac joint, this joint which is between the sacrum and the ilium, we call it sacroiliac joint, extending from the sacroiliac joint till the pubic bone here. This smooth rounded border, we call it the arcuate line. Then we have the pectineal line. This is called the pectineal line. This is a line on the superior border of the pubic bone. We call it pectineal line or pecten pubis. It has another name called pecten pubis. This part, okay, also here, It's also called the pecten pubis or the pectineal line. We have the iliopubic eminence. The iliopubic eminence at this part, it's an elevation at the junction between the iliac bone and the pubic bone. We call it the iliopubic eminence. Then we have the pubic tubercle. A bony projection also on the superior pubic ramus. Of course, the pubic bone, by the way, is formed of two rami, or arches, I mean, rami or arches. This one is the superior one here, and this one is the inferior one. On the upper border of the superior one, we have a bony projection here. We call it the pubic tubercle, followed by another ridge here, just near the symphysis pubis. It's called the pubic crest. So we have the pubic tubercle, which gives attachment to the inguinal ligament, and the pubic crest, which gives attachment to another tendon called conjoined tendon. Of course, the tendons will be discussed in our main course, inshallah. So this is called the obturator foramen, covered by the obturator membrane. This is called the sacral promontory, which is the upper border of the sacrum, the anterior upper border of the sacrum, called the sacral promontory. And we have the pubic arches. Like I told you, we have superior pubic arch and inferior pubic arch. Or we can replace the word arch by the word ramus. Okay, so we have superior pubic ramus, or superior pubic arch, or inferior pubic ramus or arch. And ramus, the plural word of ramus is rami, of course. So this is the pubic arches, and we have the subpubic angle. Of course, the pubic arch, when we say pubic arch without, specifying, are we talking about the superior rami or inferior rami, we usually mean the inferior one. Because these arches, okay, the inferior one, I mean, when they meet together, they form what we call the subpubic angle or the pubic angle. This is made by the convergence of the inferior rami. Okay, this is called the subpubic angle. And of course, the angle or the subpubic angle here differs according to the type of the pelvis. Okay, but of course in the female pelvis it should be wide subpubic angle, and this allows normal vaginal delivery, one of the criteria of a good capacious pelvis that allows normal vaginal delivery. This is one also of the applied anatomy parts, and I'm going to give you a hint about the different types of the pelvis later on in the last slides of this part. So these are important landmarks that we should consider to know before going through the other parts of anatomy, like knowing the ligaments, muscles, and joints and everything. Am I clear so far, everyone? Okay, that's great. Moving to the next part. This is the sacrum, of course, one of the important bones in the pelvic girdle. And of course, the sacrum is made up of 5 fused vertebrae. And it has a posterior surface and anterior surface. The anterior border of its upper part, we call it the sacral promontory, and this part is at the lumbosacral junction. Here is the 5th lumbar vertebrae joining the sacrum, and we call that the lumbosacral junction. We have 4, as we can see, 4 sacral foramina on each side. Okay, 4 pairs, I mean. 4 pairs of sacral foramina, each pair on one side of the sacrum, and these 4 pairs of sacral foramina transmit the S1 to S4 nerves, or from sacral 1 to sacral 4 nerves. While there is a canal at the lower end of the sacrum, we call it the sacral hiatus. The sacral hiatus. And this sacral hiatus transmit S5 nerve, or the fifth sacral nerve. And you can know uh, the position or the anatomical landmark of this hiatus by palpating two bony projections on each side of the sacral hiatus. We call them the sacral cornea. The sacral cornea. And this is in case of making what we call sacral block. What is sacral block? It's one of the local anesthetics technique by injecting anesthetics at the S5 nerve to block the innervation of this part. Okay, this is by palpating these two bony projections on each side of the sacral hiatus and then injecting the anesthetics at this part. One of the anatomical variations in some individuals is that some of the people have the fifth lumbar vertebrae fused with the sacrum, There is no separation between them. Okay, may be part of the sacrum, fully or partially. And this is called sacralization of L5, sacralization of lumbar 5 vertebrae. And in other people, the first sacral segment or vertebrae is a part of the lumbar or vertebral column, like it's separated from the other parts of the sacrum and it's adjacent to the fifth lumbar vertebrae. And we call that lumbarization of S1. These are anatomical variations among individuals, and these are considered normal variations, okay? The dural sheath, which cover the spinal cord, terminates at the level of second sacral piece. At the level of the second sacral piece, this is the termination of the dural sheath. This is the end of the dural sheath which cover the spinal cord at the level of S2. And this is a very important SPA question in anatomy, okay? One of the landmarks that you should know or remember that at the level of S2 is the termination of the dural sheath covering the spinal cord. Now talking about the pelvis as a general, okay, we have two parts. We have a part called the false pelvis. This is the greater pelvis or the false pelvis, in which it has no obstetric importance. We don't care about the false pelvis in relation to our practice. I mean, it has no relation to the obstetric practice. What we care about is what known as the true pelvis, which is below the pelvic brim. This is called the pelvic inlet or the linea terminalis, or also called the pelvic brim. So we have the pelvic brim, pelvic inlet, linea terminalis. This is all the same meaning, which is the entrance to the true pelvis. Okay, so that's the true pelvis, which is formed by inlet, then pelvic cavity, then outlet here. And we are going to discuss each part separately now. This is another 3D diagram showing you what's meant by the false pelvis, surrounded or covered or enclosed, a better expression, enclosed within the ala of the ilium and the sacrum. Okay, this is called a false pelvis, and this is of no obstetric importance. But the other lower part here, from the inlet to the outlet below, this is called a true pelvis, and this is of the obstetric importance because the diameters here affect the progress of the child birth. Of course, the clinical application of examining the diameters and so is to determine that if there is what we call cephalopelvic disproportion or not. What's meant by cephalopelvic disproportion? This means that the clinical assumption by the obstetrician that the relation between the fetal head and the pelvic bones is not good or proportionate to allow vaginal delivery. So, of course, this comes by experience and too much practice that when you examine a female pelvis before labor, that you can see that if this pelvis is capacious enough to allow delivery or not. This is not only the thing we examine. Of course, we examine other things like the station of the fetal head, the cervix, and whether the cervix is favorable for induction or not. These are other things. But of course, one of the things that we should consider also the pony pelvis. Sometimes you examine a female that you find that her pelvis is too narrow, okay, especially on those females who are having short stature, for example, that you feel that there is some sort of cephalopelvic disproportion, and if you allow vaginal delivery, the progress may be protracted or stopped, or even it ends by obstructed labor. So, of course, this comes by good experience plus applying what we call the partogram during delivery, that you examine the patient and you see the progress and the descent of the fetal head and see that if there is need of intervention or not. Anyway, let's start talking about each part of the true pelvis. As I told you that we have three parts: the inlet, the outlet, and in between we have the cavity. So we have inlet, outlet, and cavity. Of course, this is a side view of the pelvis for a woman in a standing position. If you are looking from a side to a woman or any individual from a side view in a standing position, this is the shape of the plane of the inlet. This is the plane of the inlet. This is the plane of the outlet, and this is the axis of the pelvic cavity. This is, of course, the concavity of the sacrum, and this is anteriorly the symphysis pubis. Now let's talk about the pelvic inlet. The pelvic inlet, the entrance to the pelvic cavity or the true pelvis. This entrance or this pelvic inlet or pelvic brim, or what we call the linea terminalis, or also can be named the terminal line. These are all names or synonyms of the same thing. It's formed by the promontory of the sacrum. It's an imaginary line, of course, joining the the promontory of the sacrum, then the ala of the sacrum, the two wings of the sacrum or side bones of the sacrum. We call it the ala of the sacrum. Then sacroiliac joint, okay. Then the arcuate line. Then the pecten pubis or the pectineal line, the upper border of the superior pubic ramus along with the pubic tubercle and crest, then the upper border of the symphysis pubis. An imaginary line joining these structures is forming what we call the linea terminalis or the pelvic inlet or the pelvic brim. This is the inclination of the plane of the pelvic inlet. What does that mean? I told you when we see a side view of a standing position to a woman and we look at the pelvis from the side and we look at the inlet plane. This is the plane of the inlet, and draw a line on the horizontal plane like that, and measure the angle between the plane of the pelvic inlet and the horizontal line. This angle makes about, of average, 55 degrees, or a range we can say from 50 to 60 degrees with the horizontal plane or the horizontal plane on the standing position. Okay, so this is the plane of the inlet, like you can see, from the sacrum posteriorly to the upper border of the symphysis pubis anteriorly, and extend this imaginary line and draw another horizontal line, measure the angle in between, it equals to 55 degrees, or this is the average, and the range is between 50 to 60 degrees. Also, this is a very important exam question. And another thing which causes some confusion is the angle between the vagina and the horizontal plane. This is another part when we discuss the anatomy of the female genital system. Of course, if this is the introitus, and we know that the vagina also extend upward and backward like that, and this is the uterus like this, okay? And if we measure the angle between the vagina and the horizontal plane, it's 45 degrees, not 55. So that's something causing confusion for some colleagues. Okay, so these are numbers that we have to remember. The angle between the vagina and the horizontal plane is 45, while the angle of the pelvic inlet itself to the horizontal plane is 55, or a range between 50 to 60. Am I clear so far, everyone? I want to make sure that everyone is following up with me.
Yes, sir. Yes, sir.
Okay, that's great. Okay, now let's talk about the diameters now. Okay, and for each part of the pelvis, whether the inlet, cavity, or outlet, we have different diameters. And also the diameters can be subdivided into anteroposterior and transverse and diagonal, okay, or oblique diameters. Now we are still talking about the pelvic inlet, or the pelvic entrance. And for the pelvic inlet, we have three types of diameters. We have anteroposterior, we have transverse, and we have oblique diameters. Okay? Now let's talk about the anteroposterior diameter. Let's talk about the anteroposterior diameters. The first diameter we have, it's called the anatomical anteroposterior diameter, or the true conjugate. The true conjugate. This diameter extends from the tip, sorry, extend from the tip of the sacrum here, posteriorly, to the upper border of the symphysis pubis anteriorly. We call it the true conjugate, this line, true conjugate, from the tip of the sacral promontory posteriorly. And by the way, this is a common point for all diameters. For all the three anteroposterior diameters, we have one common point posteriorly, which is the tip of the sacral promontory. Then from this point, we will extend three lines. One line going to the upper border of the symphysis pubis, and we call that true conjugate, or anatomical anteroposterior diameter. Then another line to the most bulging part posteriorly of the symphysis pubis here, or at the back of the symphysis pubis, I mean. This is another line. We call it the obstetric conjugate or obstetric anteroposterior diameter. And the last one, we call it diagonal conjugate, which is from the same point to the lower border of the symphysis pubis. So it's easy to remember the origin and the last point. We can make it a common point, the tip of the sacral promontory posteriorly, and then extend three lines. One to the upper border, one to the middle in the most bulging point at the back of the symphysis pubis, and another one to the lower end of the symphysis pubis. The first one we call anatomical anteroposterior diameter or the true conjugate. It's about 11 centimeter, and according to this diameter, we classify what we call the contracted pelvis types. Of course, it's now not common to call it contracted pelvis or not. As I told you, it's a relation between the fetal head and the pelvis, okay? So it's not common now to go through what we call the contracted pelvis and the types of contracted pelvis and so on, because it's a relation at the end between the baby's head and the pelvis. So sometimes you feel that as in general that the pelvis is somehow narrow, but the baby's size is small and the cavity of the pelvis or the pelvis capacity allows the baby delivery, okay? So at the end, we don't depend only on the pelvis, we depend on the relation between the fetal head and the pelvis. The second one is the obstetric, or the obstetric anteroposterior, I mean, or the obstetric conjugate. So when we say obstetric, it means that it has obstetric importance. So what is the obstetric importance? Again, I remind you that this diameter extends from the tip of the sacral promontory posteriorly to the most bulging point at the back of the symphysis pubis anteriorly. So this is called the obstetric conjugate, and it is the shortest anteroposterior diameter facing the head or confronting the baby's head as it passes through the pelvic inlet. This is the shortest anteroposterior diameter facing the baby's head through its passage through the pelvic inlet. Its diameter is actually 10.5 centimeter. We approximated to 11 centimeter also, okay? And this is for easier studying and remembering, and I will tell you why, because this one is the one we should focus on its length. So now we have from the anteroposterior diameter of obstetric importance, we have the obstetric conjugate, which is 11 centimeter. Okay, remember this number 11, anteroposterior for the pelvic inlet. The last one is the diagonal conjugate, which is from the same point posteriorly to the lower end of the symphysis pubis anteriorly. This is 12.5 centimeter, and this is the one which we can assess clinically by per vaginal examination. Look at this diagram showing a clinician examining the pelvis. So when you put the fingers below the symphysis pubis here, you can measure the distance between the lower end of the symphysis pubis till the sacrum posteriorly or the sacral promontory posteriorly. You can then measure the length of this diameter, and this is the one we can measure or assess clinically without imaging, I mean. Okay, this is called the diagonal conjugate. We have another diameter or anteroposterior diameter, which is of no clinical importance. It measures the length from the upper margin of the symphysis pubis till the fifth lumbar vertebrae, okay, or the upper border of the sacral promontory, okay. This is about 20 centimeter and it has no clinical importance for us. This is called external conjugate. So I'm going to show you a diagram showing the four diameters, okay. This is the three diameters which we care most about. Same point, tip of the sacral promontory, one to the upper part, anatomical, second one to the bulging point at the back of the symphysis pubis, obstetric, and this is what we cares about most. It's about 10.5 centimeter, but we are going to approximate it to 11 centimeter, okay? The last one is the diagonal conjugate, 12.5 centimeter. It's important that this is the one which we can assess clinically. Another one is the external conjugate, and of course, this is of no clinical importance. These are the antero-posterior diameters of the pelvic inlet. Now let's talk about the transverse diameters. The transverse diameters. We have anatomical transverse diameter, and also we have obstetric one. So when we say obstetric one, means that's the one which we care about in our obstetric practice. Anatomical is simply we are going to measure a line between the two farthest points of the iliopectineal lines. Okay? This line and this line. Okay? We are going to measure the farthest point from here to there, and we are going to measure it. It's about 13 centimeter. 13 centimeter. And when we draw this line and we measure the distance from this line transversely and to the anterior point and a posterior point, we are going to find that this line is 4 centimeter in front of the sacral promontory and 7 centimeter behind the symphysis pubis. So if we draw a circle like that and we draw a line joining the two farthest point at the sides of this circle, okay, this is called the anatomical transverse. If we measure the distance from anterior to this line, it's about 7 centimeter. This is anterior, this is posterior. Okay? And if we measure the distance from this line to posterior, it's about 4 centimeter. This is exactly how to locate the anatomical transverse. But this is not what we care most about. What we care most about is the obstetric transverse diameter. It bisects the true conjugate. It bisects the true conjugate. What is the true conjugate? Remember from the anteroposterior diameter. If we draw a line from the sacral promontory to the upper border of the symphysis pubis, this anteroposterior diameter now is called the true conjugate or the anatomical anteroposterior diameter. If we bisect this line by a transverse diameter like that, this is called the obstetric transverse diameter. Again, if we draw a circle like that, and we know that we have a line from this posterior end to this anterior end, okay, we call it the true conjugate. And I want to determine, okay, the obstetric transverse diameter. I'm going to measure this line and pick a point at the middle of this line, okay? Then draw a transverse line like that. This transverse line, we call it obstetric transverse diameter, which is actually 12.5 centimeter. But for approximation and easy remembering, we are also approximating it into 13 centimeter. Okay, guys? So that's another number we have to remember. So now we have two numbers. Anteroposterior obstetric, we said it's 11, and we have transverse obstetric, and we measure it as 13. So you can, by guessing, if we have an oblique diameter, it will be 12, and it will be easy to remember like that, anteroposterior 11, oblique 12, transverse 13, 11, 12, 13. And this is actually what we are going to confirm, the oblique diameter. The oblique diameter is 12 centimeter to make it easy for us to remember, okay? So what is the oblique diameter? We extend a line from the sacroiliac joint of one side to the iliopectineal eminence on the opposite side. This is called the oblique diameter. Okay, we name the direction of the diameter according to the joint, not the eminence. I mean, when we say right oblique diameter means extending from the right joint to the left eminence. So this is a right diameter, okay, because it extends from the right joint. If the line is extending from the left joint, left sacroiliac joint, to the right eminence, we call it left oblique diameter. So we name the oblique diameter according to the direction of the joint. The right oblique extend from the right joint, while the left oblique extend from the left joint. We have another diameter called the sacrocutuloid diameter, extending from the tip of the sacral promontory at the common point. So we have two lines. One extend from this line to the one of the eminence and the other to the other eminence. So of course, if we want to name it like right or left, we have a common point. We cannot depend on this point, the sacral promontory. So we are going to name it according to the direction of the eminence. I mean, the left sacrocutuloid is from this point to the left eminence, and the right one from the point to the right eminence. Okay, so this is, just a definition: the sacrocutuloid from the tip of the sacral promontory to the right or left eminence. Okay, this is 9 to 9.5 centimeter, but we care most about the oblique diameter, the main one from the joint to the eminence, 12 centimeter. So we now have anteroposterior of the inlet, 11. We have oblique, 12, transverse, 13, 11, 12, 13, and this is for the pelvic inlet. We are still talking about the pelvic inlet. Am I clear so far, everyone? Okay, very good. Now, about the cavity. About the cavity, this cavity or the pelvic cavity is bounded by the inlet above or superiorly, below here, a plane, we call it a plane of the least pelvic dimensions, the plane of the least pelvic dimensions. This means that these are the lowest or least pelvic dimensions we have in our pelvis, okay? And I'm going to tell you the boundaries of the plane of the least pelvic dimensions in a while. But remember, above we have the inlet, below we have a line called plane of the least pelvic dimensions. Posteriorly, we have the sacrum, and anteriorly, we have the back of the symphysis pubis. So this is called the pelvic cavity. This is called the mid-pelvis or the pelvic cavity. And the plane of this pelvic cavity is called the plane of the greatest pelvic dimensions. This is the largest or the most capacious part of the pelvis, which is surrounded by, anteriorly, we have the middle of the posterior surface of the symphysis pubis, posteriorly, the junction of the second and third sacral pieces, and laterally, the center of the acetabulum. Laterally, on both sides, the center of the acetabulum. What is the acetabulum? Again, don't forget, this is the part where the femur head articulates. This is called the plane of the greatest pelvic dimensions. The good thing about the pelvic cavity that its all diameters are the same, equals to 12 to 12.5 centimeters. And for better remembering and memory, we will call it 12 centimeter. So it's anteroposterior equal transverse equal oblique equals 12 centimeter. Okay, so all the diameters of the pelvic cavity we will remember it as equaling to 12 centimeters. Okay? So again, I'm repeating. The inlet 11, 12, 13. Now the cavity all 12, 12, 12, 12. Okay, what about the pelvic outlet? What about the pelvic outlet? The last part of the pelvis. We have two parts of the pelvic outlet. We have one is anatomical and also one is obstetric outlet. What is the difference between them? The anatomical outlet is this diamond or lozenge shaped outlet at the lower part of the pelvis. Actually, this is the same boundaries of the perineum. If we look at the perineum, okay, it's the same. These are the structures surrounding or making the boundaries of the perineum, or also causing what we or doing or making what we call the anatomical outlet. It's formed by the lower border of the symphysis pubis. Now we are looking from below. Okay, this is the pelvis view from below, like assuming that this is a patient sleeping in a lithotomy position like that, okay? And we're looking at the pelvis from below. This is symphysis pubis, lower border, and then the pubic arch, the two inferior pubic rami, then the two ischial tuberosities, these two ponies, pony projections. Then we have two ligaments here, the sacrotuberous and sacrospinous ligaments. Then the tip of the coccyx. This diamond-shaped or lozenge-shaped structure is called the anatomical outlet. What about the obstetric one? But before that, another thing to mention that if we draw a line between the two ischial tuberosities like that, we will have two triangles, one anterior and one posterior. Okay, the anterior one we call it the anogenital triangle or the anterior triangle. The posterior one is called, this is called, sorry, the urogenital triangle, urogenital triangle. And this one is called the anal triangle, because this one contains the genital organs and this one contains the anal canal and the two ischiorectal fossae. Of course, this part is also explained in details in the perineum. But what we cares about, what we focus about today is the obstetric outlet. Obstetric outlet is a segment which is bounded above by the plane of the least pelvic dimension and below by the obstetric outlet. So when we have this segment bounded by, if we assume that this is the outlet, anatomical I mean, so this is the anatomical outlet, this is the plane of the least pelvic dimension. The area between them, we call it obstetric outlet. So what is the plane of the least pelvic dimension? Simply the plane of the least pelvic dimension is bounded by the lower border of the symphysis pubis anteriorly, the tip of the sacrum posteriorly, the lower end of the sacrum posteriorly, and laterally between the two ischial spines. Between the two ischial spines. And we call it the plane of the least pelvic dimensions because, as I told you, this is the lowest dimensions that which confront or face the baby's head during delivery. That's why if the baby's head passing near the ischial spine and reach the ischial spine, we call that the head is engaged. The head is engaged. And this is a good sign. Okay, when the head is engaged, it gives us an assuring or a reassuring sign that the labor could progress smoothly. Okay, because if the head passing through this diameter, okay, means that delivery is imminent without any problem. But of course, if the baby's head is high, cannot reach the plane of the least pelvic dimension, means that there may be a problem during the delivery, okay? So this is called the plane of the least pelvic dimension. This is the obstetric outlet, the segment between them. This is, the anatomical outlet here. The segment between them is obstetric outlet. What about the diameters of this outlet? What is the diameters of this outlet? Let's talk about the anteroposterior diameters. The anteroposterior diameters also have a common point. This point, which is the lower border of the symphysis pubis, we will draw two lines. One line to the tip of the coccyx and one line to the tip of the sacrum itself, the lower border of the sacrum. This is the coccyx, the tip of the coccyx. Here is the tip of the sacrum, the lower border of the sacrum. The one to the tip of the coccyx is called anatomical anteroposterior diameter, and this is 11 centimeter, because we know that this is the concavity of the sacrum like that, and this is the tip of the coccyx. This is the symphysis pubis. I'm going to draw a line here from the lower border of the symphysis pubis to the tip of the coccyx. This is 11 centimeter. But if I draw another line from the same point, the lower border of the symphysis pubis, to the tip of the sacrum, this is the obstetric anteroposterior diameter of the outlet, and this is 13 centimeter. So the first one we focus on is the obstetric anteroposterior, which is 13 centimeter. This is another diagram also showing you the two diameters originating from the same point, the lower border of the symphysis pubis, one going to the tip of the coccyx, anatomical anteroposterior, we don't care about, other one to the tip of the sacrum, 13 centimeter, which we want to remember. Okay, so we have anteroposterior of outlet 13 centimeter. Also, these are two other diameters, imaginary diameters. If we have a line joining, the two ischial tuberosities like that, and we have a line from anterior to this line and from this line to posterior, then we have two other diameters. We call it anterior sagittal diameter and posterior sagittal diameter. Anterior and posterior. The anterior one is 6 to 7 centimeter, posterior one is 7 to 10 centimeter, but I don't see any relevance to these two diameters, and they are not asked in the exam. Now we have two other diameters, okay? One diameter, these are two transverse diameters. One joining the two ischial tuberosities, and that's what we need to remember, 11 centimeter. Sorry, this one is the widest one, 11 centimeter. And this one is what we care about, the bispinous diameter, 10.5 centimeter between the two ischial spine. These are the two ischial spine. These rounded bones are two ischial tuberosities. The narrowest one, of course, is the bispinous diameter, 10.5 centimeter, but we are going to also approximate it to about 11 centimeter. So now we have the anteroposterior, I told you 13 of the outlet. Now we are talking about the outlet, and the transverse equal 11. So now you can guess that the oblique will be also 12. Okay, so if we have the last summary of the diameters at all, we said that the inlet, we started by 11 anteroposterior, then oblique 12, transverse 13. If we talk about the outlet, it's the reverse. We started by the anteroposterior 13, oblique 12, transverse 11. So 11, 12, 13, 13, 12, 11. And the cavity, all are 12. Also, this is another diagram. These are the inlet diameters. Okay, 11, anteroposterior, oblique 12, transverse 13. If we look at the outlet, okay, anteroposterior 13, okay, then we have the oblique 12, which is, by the way, extending from the ischial spine on one side to the pubic arch on the other side. It's 12. Then the transverse 11. Is it easy now and clear? Clear, everyone? Okay, let's repeat again quickly, okay? We said the pelvic cavity, all diameters are 12. Anteroposterior, oblique, transverse are all 12. Now we are left with the inlet and the outlet, okay? We said the inlet diameters, okay? We have the obstetric conjugate or the obstetric anteroposterior diameter from the tip of the sacral promontory to the most bulging point at the back of the symphysis pubis, anteroposterior equals 11. We have the oblique extending from the sacroiliac joint on one side to the pectineal line or the iliopubic eminence on the other side, and we said it's 12. And we have the transverse, okay, which is a line bisecting the anatomical anteroposterior diameter, and this is called obstetric transverse diameter, and we said this transverse equal 13. So to remember them, anteroposterior 11, oblique 12, transverse 13 centimeter. 11, 12, 13. If we look at the outlet, this is the outlet. Now I'm looking at the pelvis from below. Okay, we have anteroposterior from the lower border of the symphysis pubis to the tip of the sacrum. Okay, this is 13. So anteroposterior equal 13. We have transverse between the two ischial spines. We said it's 11. And we have oblique equals 12 from the ischial spine to the inferior pubic rami, 12. So we have for the outlet 3 diameters, anteroposterior, oblique, transverse 13, 12, 11 centimeter. Okay, so if we summarize the numbers again, so we have the inlet 11, 12, 13, outlet 13, 12, 11, and the cavity is 12. Of course, we have to arrange them as anteroposterior first, then oblique second, then transverse as a third. Okay, so by this way you can remember the numbers without any problem. The part of the fetal head engagement, as you can see, if this is the baby's, delivering and passing through the pelvis, this pony projection is called the ischial spine. And you can palpate these two pony projections from the vaginal examination. If you palpate the vagina from inside and go through the lateral border of the vagina or the lateral wall of the vagina, you can feel this pony projection. If you feel that the fetal head reaches the level of the ischial spine, we call that this is an engaged head, okay? And this is called station zero. But of course, this needs, a detailed explanation of the process of labor. But this is called zero station, means that the head is at the level of the ischial spine. If you feel that the head is engaged at this part, means that the delivery can progress smoothly in most of the cases. Unlike if the head is felt above or below the ischial spine and not engaged, this gives some worries about the progress of labor. Okay, this is a general speaking point, but of course, to illustrate the process of labor, this is another thing that has another, or should have another meeting or another webinar. So this is what's meant by engaged head or engagement. The last thing I want to mention is the pelvic axis. Okay. Also for the pelvic axis, we have anatomical axis and we have obstetric axis. The anatomical axis is an imaginary line joining the three planes. If we have a point at the middle of the pelvic inlet and point at the middle of the pelvic cavity and point at the middle of the plane of the pelvic outlet, and we join this line, we will have a C-shaped line like that. We call it the curve of Keras. The curve of Keras. Okay, it has no obstetric importance for us. But what's matters for us is the obstetric axis, and it's the axis or the direction taken by the baby's head during the process of labor. I mean that we can assume that when the baby is delivered, it passed downward and posterior like that, downward and posterior, okay, until the level of the ischial spine, until the level of the ischial spine, then the head will move downward and forward. So we will get a J-shaped, or we can imagine it as like a J-shaped, axis like that. This is called obstetric axis. This is called obstetric axis like that. The baby is delivered, baby's head is delivered like that, passes through the inlet like that, okay, until the level of the ischial spine, then moves downward and forward like that. So it gives us this line, we call it the obstetric axis. Also, quickly, this is not a common part in an exam, but we have four types of pelvis. We have the gynecoid pelvis. This is the most common in the female pelvis. The android one, which is found in the male pelvis. We have the platypilloid and the anthropoid. Okay, what are the main differences between these types of pelvis? This is the gynecoid pelvis, which is found in 50% of the women. It's the normal female type of pelvis. This has a transverse oval shape like that, transverse oval shape, okay? And it has a moderate depth and straight side walls like that, okay? And the ischial spines are blunt, not too much projecting. It's blunt, not projecting like that. It's just blunt. And it has a wide sciatic notch, and its subpubic angle is about 90 to 100 degrees. This is the gynecoid pelvis, and it's found in 50% of the female. The anthropoid found in 25%, which we call ape-like. It's also oval, but oval anteroposterior, like that. Oval anteroposterior, not transverse. It has a long and narrow sacrum, and it has prominent ischial spine, and its subpubic angle is narrow, less than 90 degrees. This is found in 25% of the females. We have the android pelvis, which is the male type, heart shaped like that. Okay. It has also a convergent side walls. The side walls are funnel shaped like this, with a narrow subpubic angle less than 90 degrees. And the last one is called platypilloid pelvis, which is a flat female pelvis found in 5% of the cases. It's, as you can see, very wide transverse like that, with a very shallow depth and divergent side walls. The side walls are going far from each other, and it has a very wide subpubic angle more than 90 degrees. This is called platypilloid type. I have never seen questions asking about the different types of the pelvis, but these are the common differences. It's important to know the percentages, like 50%, 25, 20%, and 5%. By this, We come to the end of the scientific portion of the webinar, the pelvic diameters. I hope you understood all the information mentioned in this part. And before I end the session, let me explain to you what we are doing now in our course. We already started on the 12th of January what we call the pre-course activities or the warm-up phase. Here we provide our dear colleagues with recordings of different topics. On daily basis, they listen to these recordings, and our dear moderator, Dr. Nora, is sharing questions on daily basis to practice. And by the end of this phase, they are going to get a quiz of 50 questions to test themselves on the previous topics. Then we will start after that the main preparatory phase, which is the live session phase. And this phase will include the statistics workshop by Dr. Desiree, my dear partner in this course. And then we will end up by the revision phase, in which we are going to discuss all the past exam questions. And we have another course, which is the progressive course, which will start on April. This is a quick revision course or a condensed course in which we are revising the subjects on bundles or in bundles. Each bundle contains 2 or 3 subjects, and also this course include a recalls workshop before the exam. If we look at this schedule, this is the pre-course activity phase or the warm-up phase, where the candidates are having these recordings on daily basis. All they have to do is just to listen to the recordings and practice with the moderator on our Telegram group. After finishing the warm-up phase or the pre-course phase on 27th of January, we are going to start the live session phase. As you can see, this is the live session phase schedule. Like for anatomy, we are going to have 2 sessions on 28th and 29th of January. We are going to have the anatomy on 2 live sessions. After that, we will have a study duration, okay, till the 5th of February. In this study duration, we are going to provide the colleagues with a schedule, okay, so that they can manage their time, and also will have a daily discussion with the moderator, okay. And after that, we are going to give them an access to a topic test on our website just for anatomy, including 100 questions for anatomy to test themselves. Okay. Also, during the study duration, before I forget, this study duration also will include the anatomy topics given in the pre-course phase. I mean, for example, here in anatomy, in the pre-course, we give a recording for the anterior abdominal wall anatomy, breast, fetal skull, male genital system, abdominal incisions, and nerve injuries with gynae surgeries. Okay? Even if a colleague joined us late and missed this part from the pre-course, we will give a time for these recorded topics to be covered again during the study duration. So even if you feel that you haven't covered the topics in the pre-course phase because you joined late, or you feel that you haven't digested the topics good or well, then you will have another chance to revise them during this study duration before you apply for the topic test. And the same applies for all other subjects, okay? The same strategy will be applied for all other subjects until we finish the course by the statistics workshop with Dr. Desiree from 8th of May to 14th of May, inshallah. This is the progressive course plan. As you can see, each course or each bundle contain 2 subjects, except for one bundle which contain 3 subjects, the last one, biochemistry, pathology, and immunology. Here we do the reverse. I mean, we give access to all the materials of these subjects to the colleagues who join us on the progressive course. They will have the time to study, to access the recordings, and discuss in the study room. And after that, we will have a live session just for discussion and highlighting the important points, not for thorough illustration. No, the live session for the progressive course is just for discussing questions and highlighting important points. And also after that, the candidates will get an access to another topic test where they are going to evaluate themselves. Then the progressive course is ending by a recalls workshop in which we are going to discuss the recalls on daily basis with the moderator in the group. And through this, workshop, we will get also 4 meetings, 2 with Dr. Desiree and 2 with me. Okay. So we are going in this meeting to discuss any confusing points and giving the advice before the exam. Of course, our study room is on Telegram, and because this platform allows us to share polls and questions, and also any materials are saved there. And even if you join late, you can access the old materials, unlike other platforms. Also, the live sessions are all recorded. All the live sessions are recorded. So if you miss the live session, you will get access to the recordings, and you will get also an enough study time for each subject. So I want to stress on this part that the sessions are recorded, and this I know is very important for many of the colleagues who cannot join the live session because of the time difference, maybe, or because they have other commitments at the same time. So you will have a recording, so don't worry about that. The online test, you will have the same exam format. The test is computerized or computer based, and the same on our platform. You will get the same format. So once you practice on our website, you will feel exactly like you are doing in the real exam. The statistics workshop is a separate workshop for statistics. I know this subject is making problems for many of the colleagues. We used to give this subject as one of the subjects, like other subjects, I mean, in the live session, but because we feel that colleagues need more time and focused stress on this subject, we have separated that in a separate workshop. And this separate workshop is not only for part one candidates, but also for part two candidates as well. So by this, we come to the end of our webinar. And before closing the meeting, if you have any questions or queries, I will answer, inshallah.
Sir, do we need some other books to study, or only these live webinars and these are enough for us?
No, you will get a PDF material after each subject, and these PDF materials are more than enough. Why? Because actually we made these materials from all the different books of MRCOG in the market. So don't worry. We have gone through all the books, and we have gathered all the relevant information, okay? And we put them in one place. So that's why people take a course, to make things easier for them, okay? So don't worry about the materials. All the materials you are getting from MedExam are more than enough regarding questions or theory part, okay?
Thank you, sir. Thank you so much.
You're welcome. Yes, you can take the test later on, but okay, that the people who are going to take the test on time and they get high score, okay, we give or mid exam doing like something like a funny competition. It's not like a real competition, but something to make you study and feel some fun during the course, because those who are getting high marks through the exam on date, okay, they will get like some rewards from mid exam by the end of the course. The team, the support team, can tell you later on what is the kind of rewards you can get. Okay, but you can take the test, because the test, once the test is open for you on the platform, it will remain open until the day of the exam. You can take it at any time, and you can repeat taking it. Okay, so for example, if you score like on the first trial, you scored 70% or 75%, and you are not satisfied, you need to repeat the test again, you can repeat that to improve yourself. But for the reward matter, the high, the first score is what we consider. Okay, so that's what how we can make people study and go for the exam on time. Any other questions? Okay, thank you so much everyone for joining me in this webinar. I hope you enjoyed it, and stay tuned for other webinars. We are going to announce for other webinars soon, inshallah. And for our dear course candidates and colleagues, I think now you know about the strategy, and it's very important if you already joined us to study on daily basis with Dr. Noura. Like I told you, try to cover the recordings and then go for the discussion. It's just a warm-up phase, but it's a good thing to get into the mode of studying and know more about the syllabus. So I wish you all the best of luck and see you soon in other webinars. See you. Bye bye.